So without further ado, we open the ECLS session of the Sanibel Symposium with Dr. Matt Paden. Dr. Paden is a professor of pediatric critical care at Emory University and the director of pediatric ECMO support at the Children's Healthcare of Atlanta. Dr. Paden, affectionately known as Matt, has been a true friend to me through our years in the ELSO organization. He played a big role in the mastery of the powerful ELSO data registry, and he is the current president of ELSO. That is a tough position as ELSO now combines 5 chapters globally. So I believe he has some interesting traveling coming up as he usually shows up at all the chapters around the globe in the next year. His presentation is entitled The ELSO Registry, an important tool to improve care, quality, and patient outcomes. I believe Dr. Paden has submitted his presentation as a video this year, but he is online live for questions afterward, time permitting. So, Brian, if we can cue him up. Thank you, Dr. Paden, for joining us today.
Thank you, Bill, for the introduction. I am Matt Paden. I'm a professor of pediatric critical care at Emory University and Children's Healthcare of Atlanta. I'm also the current president of ELSO. And I got asked to speak here today on the ELSO Registry, which is an important tool to help improve care, quality, and your patient outcomes. I'll start with my disclosures again. I mentioned that I'm the ELSO president and board member. I've been funded in the past by NIH, FDA, and others for some ECMO medical devices, none of which I'll talk about in this talk. And then everything in ECMO, at least in the United States, is off-label use. So with that, I have 2 objectives for this talk today. One is to discuss the history and growth of the ELSO registry as the gold standard for ECMO outcome data. The second is to describe how to use ELSO registry data for quality improvement projects at your own center. And so I do want to start with the ELSO registry and a little bit of history. The ELSO registry was started in 1989 to collect outcome data for ECMO patients. The ELSO registry has grown a tremendous amount since then. The ELSO registry, when it first started, was all done on paper. The forms, which were mailed to Ann Arbor, Michigan, where Peter Rikus, who's run the registry for a long period of time, would then hand enter them into the computer. We've made some progress over the years, first by progressing to that novel innovation of a fax machine to fax them to Peter, and then eventually to email. And now we have a online ability to enter all of this data in, which is much better and much improved over that, over where we started. ELSO registry is the largest source of ECMO outcome data in the world. We have a little over 133,000 patients at the end of 2020. We're collecting a little over 15,000 ECMO runs a year that are distributed over the 463 ELSO centers worldwide that contributed data in 2019. The ELSO registry is a big portion of ELSO, and it has 2 core ideals that underlie its use. The first one is validity. If we don't have validity and the data that we're collecting is not valid, then any kind of testing or modeling that we're going to do based on that data is really not going to be worth much. And so we really strive to make sure we have good data validity. The second issue and core ideal that comes into this is one of value, that if we're going to ask our centers to take the time to collect all of this data for us, that data has to be able to provide some value to the ECMO center itself, but probably more importantly to the patients who we're doing all of this for. From the standpoint of validity and value, those are the 2 core ideals that underlie the ELSO registry and what I'm going to focus on today. So validity all comes back to one thing, and that is data definitions. Again, we've got more than 400 centers all across the world that are entering data. We have to make sure that we all have a common language that we're speaking, and that's where data definitions come into this. This is the front page of the ELSO data definitions, which you can find on the ELSO website. You can see they were last updated in January of 2021. I'm not going to sit here and go through all of the data definitions with you. Even as someone who enjoys and likes this kind of thing, that would be boring for all of us. I will point out, though, I'll show you, this is the second page of the table of contents of this, showing that we have 113 pages worth of data definitions. We've gone through this to, again, really from the outset, make sure that we've done a good job of making sure that we're all speaking the same language in this, because it's really important. Now, while I'm not going to go through all of them, I am going to take some time to go through a few of these so you can get a sense of the level of detail that we're collecting here. And so I thought I'd start with equipment. Our perfusionists are our local experts in the ECMO equipment that we use and see you as such. And so if we're talking about, this happens to be the data definition for a membrane lung. And so you see for each field, you've got the name of the field here, you've got a definition of what the membrane lung is, and then an explanation and an example of how you select this. You'll also see over here if we've got any specific data entry rules, and then we've actually got the database of where these things are stored in here. Now, the other thing that we have is included in this is, you see down here, we've got device start, time, and end. So one of the things that you'll notice on this page is the top here is from 1989 to the present. This is things that have been added in the beginning of 2020. And so if you were looking at ELSO data before 2020 and you would look, an ECMO complication of having to replace your membrane lung either happened or it didn't. And so if you replaced, when you were looking at ELSO registry data, if you replaced 10 lungs during a patient's run, it looked exactly the same as if that patient had had one membrane lung replaced. And so in 2020, as an addition to the ELSO registry, we added changes here to where we're doing recording start and stop times. This allows us to do a whole lot more complicated analysis of this. We can look, for example, of time to first failure. We can look at mean time between failures of oxygenators for these patients. So we get into some of the kind of engineering analysis that we really need to do moving forward. Now, the other thing that we collect in terms of membrane lung is, if the device does get replaced, why did we replace it? And so again, your definition here goes down and talks about all of the different reasons why a membrane lung may be replaced, from it's not exchanging gas anymore to I'm seeing increased resistance to blood flow, to things down here like center protocol. We have some centers that that routinely change components. And again, we're collecting this on each of the patients whenever they have a membrane lung that's exchanged out. You see over here we have all the ways these things are coded in the registry so that we can capture that data. Hemorrhage is another thing that is a common area where a definition becomes vitally important. So you see here we have 3 different places where we're collecting bleeding complications. But I think we all would agree that bleeding complications and how much contributes serious bleeding differs, and it differs depending on who you talk to. I can tell you that the bedside nurse, the critical care doctor, and the cardiothoracic surgeon all have very different definitions of what significant bleeding is, right? I think we all see that on a day-to-day basis. And so, but in terms of the registry, we've actually specified here and have definitions that are different for neonatal and pediatrics as they are for adults. And so, again, you can see that there. And again, we record over here when we made our changes, losses, and we actually now talk about specific amounts of how much was lost. Again, these allow us to be able to do much more complicated analyses than we were able to do in the past. And again, keeps us all speaking the same language for this. And then a final thing to look at is outcomes. And so this is one of the most important reasons, and what I'm showing you here is the reason that we came off of ECMO. And so we have expected recovery, that the patient was expected to go on and do well, and that's why we came off, or the opposite of that, the patient was doing poorly and the family decided to withdraw care, or did we come off for ECLS complications? But then as things have changed over time, you've seen that we've got other reasons why patients might have come off. And so did they transition to a VAD, for example, or a pumpless lung assist? Were they transplanted? And again, you see that if we were looking through 2018, really you only had these first three options that you could say was the reason the patient came off. From 2018 on, now we've got better data on all of the other reasons why a patient may come off ECMO. Again, allows us to do much more complicated analyses than we were able to do in the past. So the data definitions, again, are a core part of registry validity. Now, but none of the definitions make any difference if the folks who are entering the data don't actually know what the data definitions are or aren't using them appropriately. And again, I think in data analysis, we've all heard this concept of garbage in, garbage out, that your analysis is really only as good as your data is. And so one of the things that we've done to help with that is this ELSO Registry data entry exam. So now you cannot enter data into the ELSO Registry until you've actually passed a data entry exam. This puts a barrier of entry, and really more importantly, it makes sure that, again, we're all speaking this same language. So if I were to go and actually go to the ELSO website and try and enter data, it tells me here I haven't finished the data entry exam. And so these are 52 questions that we've put together. They're all case-based scenarios, as you could see here. So here's a 16-year-old who was cannulated, and you've got a whole bunch of different time periods here. And the question revolves around, what is the correct ECLS start time for this patient? Is it the time when the procedure began, when the cannulas were placed, when ECMO flow was first established, or the time when you get to full flow? Again, all of these could be right, but the data definition gives you a specific correct answer for this. And again, so that we know that people are doing this according to the definitions. Now, the other thing that we've done is, while we've got the data definitions that people can always go back to, we also try and provide other learning opportunities for folks. So COVID is what many of us have been dealing with for the last year. When we added a bunch of new COVID variables on, we created some YouTube videos for our ECMO centers to be able to show them how to enter this new COVID data. This was something that was very well liked by the centers, and something I think we're going to continue and do more of in the future. So if making sure the folks who are entering the data is important, then we also go to our next set of validity checks, which are point of entry validity checks and minimum data set required. So again, I'll go back and show you one of our data definitions. And so first thing you notice about this is the field name over here, birth date, is in this kind of purple color. This tells you it is part of the minimum data set. As it shows you over here, it's a required field. You have to enter this. You will not be able to complete this patient in the ELSO registry without entering this data. It's another way where we make sure we're getting all of the data that we need for these patients. The other part that's in this is validations. And so again, for birth dates, you see I've got something here in green and something here in red. These are soft and hard limits on these patients. And so for birth date, you'll get a notification if you put a birthday in that makes the patient more than 70 years old. So we agree that, yeah, this could happen. There are some more than 70-year-olds who go on ECMO, but there's a pretty good chance that it could be an error as well, and that somebody's put something in. And so if you put someone in who would make a birthday that would make them more than 70 years old, we'll just ask the question, are you sure this is right? Please double check it. Now, there are some things that are hard limits that we just won't let you put the data in because the chance of it being wrong is just so high. So a good example of this is a date of birth. If you put it in and your date of birth is before the time and date that the patient went on ECMO, again, that's probably going to be wrong. Again, patients more than 100 years old, that's in the vast majority of cases, that's going to be wrong. And so we put a hard limit in there. Now, if you decide to put a 101-year-old patient on, that's fine. Give us a phone call. We can take care of that for you. But again, that's there to help protect errors at the time of data entry. And so we do all of those things to try and collect. And then the other thing that we do is we do an internal, for those centers who apply for the Center of Excellence, we do an internal validation of a random 10% of their patients. And we do that in order to check and make sure. So that's an internal validation. Now, the ultimate in registry validity is to have a third party validate this. And so we've actually hired a company that approaches centers and does external validation. And we've got that going on in centers in 2021. The reason we, again, go to all of this trouble to make sure that this data is valid is, again, what's right there at the bottom. Your analysis is only as good as the data that we have in the registry. So if we move from validity to a minute to value, one of the key things is if we're going to go through all of this trouble to get good data in the registry, we want our centers to be able to use that data. And ELSO, running queries of the ELSO registry was something that was difficult in the past. In the past, what had to be done was you picked up the phone, you called Ann Arbor, Michigan, you talked to Peter, you told him what clinical issue you were facing, and he would translate your request into a SQL query, query the database, and give you back your answer. Problem with that becomes, of course, that in a worldwide organization, that no longer scales very well because you're reliant on one person being available from 8 to 5 p.m. During the week only. And we all know ECMO doesn't occur at any of those times. And 8 to 5 during the week Eastern time means half of the world is asleep, right? So again, for a worldwide organization, this just doesn't work. So one of the things that we developed is something called the ELSO Outcome Reporter. And this is a place where you can go on the registry website, again, log in and you'll be able to see this. You can select which patient population you're looking at, pediatric, neonate, adult, what kind of ECMO they have. And then you'll be able to enter ICD-10 codes for whatever disease you happen to be looking for and wanting to know the outcome of. So in this case, we were looking at methicillin-resistant Staph aureus sepsis. We selected those ICD-10 codes there, and then click the filter button, and it spits out the data, all of the data that we have in the registry for those ICD-10 codes, as well as the data for the last 5 years. So in this case, you see there were 70 cases in there, pretty lousy outcomes at about 28%, whether we're looking all time or just for the last 5 years, and roughly 10-day lengths of run. So again, this provides a way that we can get information back to the centers and allow them to query any time of day or night, wherever they are in the world. The next part of value is one that is our most requested thing, and that is integration with the EMR, to take all of those data fields that we're having you put in and be able to take them directly from the EMR to the ELSO registry. It's a much tougher problem than it sounds like, but we're moving in that direction. And so there is something called XML, and so it stands for Extensible Markup Language. And most EMRs can take data fields and export them into this XML format. And we have there, if you go, you can see how to get there here. We have the forms that you can do, and oftentimes this is going going to require partnership with your local IT providers to be able to get them to do this. But it makes a way where all of that stuff will be dumped into an Excel spreadsheet for you that then is easily uploadable into the ELSO registry. So this is not complete integration with the EMR, but it is a nice first step, and again, something that many of our centers have asked for and that we've been able to provide. Now, I could sit here and talk about updates on the ELSO registry over time for a long time, but I want to get to some of the other points in this. I would point out these three papers that talk about it. The first one, again, talks about this importance of the value that the ELSO registry can bring. The second paper is looking at all of the papers, important papers that have come out of the ELSO registry over the last decade. And the third one discusses a bit more about where the ELSO registry has been useful, not just in providing papers, but in getting devices and medical devices approved for use, both with the FDA here in the United States and around the world. And so it's been a very useful tool for us. Now, help is always needed with this. Ryan Barbaro is who runs the ELSO registry right now and is our ELSO registry chair. He's got a registry development committee that talks about improving that value and validity of the data. There's a scientific oversight committee, which when you put a request in for ELSO data, this is the group of folks who look over it to make sure that we can actually answer the question that you're asking with the data that we have. And then the final committee is one that looks at improving the quality and using this ELSO quality reporting platform to be able to do some of the things that I'll show you at the end of this talk. So if any of you all are interested in this, I'd encourage you to reach out. I'm going to switch gears here for a minute and actually show you some data from the ELSO registry. And this will look familiar to many of you all who've seen ELSO registry data before. These are the overall outcomes. And again, as you can see here, we're up to about 133,000 patients with approaching 75,000 survivors for this therapy. And so these are the overall outcomes from the registry, again, from 1989 until through 2019. We also showed the data from just the last 5 years and present that alone. And again, I think the thing that is important and that probably doesn't need to be said to this audience is just really this rise of adult ECMO. So again, in the last 5 years, you've seen, what is that, 43,000 ECMO patients. Again, if we look overall, you're talking about 50 some. And so 72% of all of the adult ECMO that's in the registry has been done in the last 5 years. And so again, that's just a huge jump in the rise of adult ECMO that I think we all see every day at the bedside. The other thing we present in the ELSO registry data is things like center volumes. And so again, if we're looking at adult center volumes here, this is a box and whiskers plot. And so if you're not used to seeing these, the line here is what the median is, and the tails of these are the 90th percentile. And so you see the median adult ECMO center does about 18 cases of adult ECMO a year. If we're going down to pediatrics and looking at kids, again, the median center does 9 cases a year. So for the vast majority of our centers, ECMO is not something that is done very often, which again makes quality initiatives of these rarely performed procedures even more and more important at your center. The other thing that we report out from the registry are the complications. I just picked offhand here the adult respiratory complications, but you can see we report out, and this isn't all of them, this is just some, but we'll report out the number of them, what the percentage was, and then percent survival for patients who had that complication. And again, that ends up being important because you can look at what some of the attributable mortality to some of these complications are. Now, again, what most of us have been dealing with for the last year is COVID, right? And this pandemic really demonstrated the need for near real-time data entry to the registry as well as data reporting. And this was a huge change in practice from the previous 40 years, and even for the H1N1 pandemic. During the H1N1 pandemic, we were still filling out very brief forms and emailing those to Peter. We needed to be able to do something more than this. And so this data you see over here to the side, I pulled from the website this week as I was putting together this talk, and we're up over 6,000 patients that have gotten ECMO for COVID, and we have about 50% hospital mortality, and you can see there from all over the world. And this turned out to be a really important thing that we were able to do. So this is a paper that was published from the ELSO Registry looking at 90-day mortality in COVID patients that received ECMO. And you see here that the mortality rate was just less than 40%. So not that different for these patients compared to other respiratory ECMO patients who went on. And again, we were able to collect this data from, in this cohort of about 1,000 patients, from 213 hospitals around the world. And all that's really important because, as all of us remember as we went through this, especially in the early days of this, we didn't know what the right thing to do was for these patients. And you had a group of people out there saying ECMO should never be used for COVID patients. You had another group of patients out there saying it absolutely should be used. And this was a way that we rapidly used the registry, and Ryan and his colleagues deserve all the credit for this, to be able to answer this question. It was published in The Lancet, which is wonderful. But to me, the more important thing in this is it was published in September of 2020. And again, we were doing 90-day follow-up on these patients. So you're talking about that takes you back to June from when this was published. So within really that first 6 months of the COVID pandemic, we were able to very rapidly collect data on 1,000 patients to inform what real-world use looked like in this, and that it turned out to be a very reasonable thing to do for these patients. So that was 1,000 patients in September. I'll show you where we are now, which is up to, again, over 6,000. And mortality has creeped up some, again, to about 50% of these patients are surviving. And so if you go through the ELSO website and look at this, you'll see we've structured our ELSO COVID dashboard to look very much like the registry paper. And so you'll see we've got the breakdown of patients here of who died and who got discharged from this. I'll move kind of quickly through this, but you can see where the ELSO patients were in the world who had this happen. And where they were. We looked at pre-ECMO factors for these patients. Again, in looking at that paper, we divided them up between all of the patients and then the patients who met a specific criteria for ARDS. And so, again, these are just some of the patient factors. We, again, can look at what happened to them before they went on ECMO, how many of them got high flow versus CPAP or BiPAP, how long they were intubated before ECMO, and what kind of ventilators were being used. And then, importantly, we were able to look at outcomes for these patients. So not only just who got trached, but how many of them died, and again, where they were discharged to. Complications ended up being a really important part of this. And so, again, I show you a subset here of complications, but I'll give you one example. And so, again, very early in this pandemic, you had folks worried about the thrombogenic complications of COVID-19. You had a group of people arguing for we should be anticoagulating these patients different than everyone else. And so, again, looking at the 6,000 patients that we have in the registry now, you see about a 4% risk of thrombosis or clots in the circuit. Now, I'll go back to the real registry report. Again, looking at the last 5 years from 2015 to present, again, looking at that same category, and again, this data stops in 2019, so it's not including those COVID patients, you had about a 9% risk of thrombosis. So I don't know, and we'd have to do some statistics to see if this 9% is really different than this 4%, but I think what we can say from this is the COVID patients are not, that number for them is not 25, 30, 40%, right? And so this is, again, a real world opportunity to be able to look at and compare these complication rates. So that's some of the data about what the registry itself can provide in terms of patient outcome data. I'm going to switch gears one last time for this talk, which is to move to this quality reporting platform, because this part of the talk is about, Matt, it's great to be able to get all those numbers in the registry, to know that they're actually valid, and to be able to report them out in nice kind of reports that our administrators can see. But how does it actually affect my patient? And that's really where this quality reporting platform comes in. And this is something that ELSO has built with our Arbormetrics colleagues to be able to provide a good dashboard and a good way to be able to look and benchmark your outcomes versus other centers, and to be able to do this in a way that's both useful to your centers, your administrators, and your patients. And so if you come down on the registry list here, you'll see once you've logged in, you'll see the quality reporting data link here. There's some information on how to run it, but then if you click on this last link, it'll actually take and let you log into the quality reporting platform. And when you do, you'll be met by something that looks like this. And so again, what I'm going to show you here is data from my center, and this was data that I looked at earlier this week. So when I log in, the first thing it meets me with is mortality reports. And so again, you can see it's my center here. The data I'm going to show you is from my pediatric ICU. I won't show you our neonate data and our cardiac data. I'll just show you the data that I'm responsible for. And so for us here in blue, our mortality rate compared to the rest of ELSO is less. So that's potentially a good thing for my patients. And when we look, we've been pretty much consistent there. You see 2021 has not necessarily been a good year for us. We've had less ECMO patients, and unfortunately many of them have died. And so you can see this, and then again, you can see how you compare here to other centers in terms of your mortality. Now, that in and of itself is useful, but another really interesting portion about this is you can go and compare yourself to other peer groups, and you'll have multiple other peer groups that you can choose from. And so for me, if I go, one of those drop-down menus here has all of the different peer groups that I can compare to. So I can compare myself to the rest of North America. I can compare myself to higher volume centers, all of ELSO, centers that have won the Center of Excellence Award, and things like that. Now, it is important to note that all of these peer groups are not going to be available to everyone. And so, for example, patient volume. We're a high volume center that does 60 to 70 ECMO patients a year. Therefore, the only group I can compare myself to are other high volume centers. Each of these high, medium, and low have definitions, and you can only compare like against like, okay? But the other thing you can do is you can look over different periods of time. You can look over different kinds of ECMO that you're doing and be able to do this. So that rather simple graph that I showed you earlier, now if I choose some of these, so again, if we look over here, just my pediatric ICU, now I'm comparing myself against all of ELSO, just the North American region, and other centers of excellence. And so you see we've got the ELSO data here in the darkest green. The next darkest green shows the North America region, and the lightest green is Center of Excellence. And so, again, we can compare ourselves to other cohorts, and it allows you to do some benchmarking to see where am I having problems. So that's just the mortality report. We've also got a complication report, and there are various ones of these. I'm going to show you the one that is benchmarked per 1,000 run hours. And so again, for this, you see, if we look at just my unit, our complications are less than the ELSO average. And so again, that's something that should be good for my patients. But drill down here a little bit more. And what I showed you up above is any complication. We also have definitions for major and minor complications. And if you look at my center, for example, while overall, yes, I have less complications than the ELSO cohort, I actually have more major complications than the ELSO cohort. And the only reason my overall number looks good is because my minor complications are less. I'd say my patients probably aren't too happy about the fact that I have more major complications. And the other question this would lead me to ask is, do I have less minor complications because we're actually doing a better job in that? Or is this just that we're not recording, right? Because it could be both. So again, this gives you a way to look at this where you can then try and drill down on some of this information to figure it out. I'll show you one area where we're not as good as the ELSO registry, and this is in our mechanical complications. So again, you see our rate is higher than the rest of the ELSO, the rest of the other centers. So let's drill down into that data. I'll go and look at blood pumps because that's one of our more common mechanical complications. And so we have two kinds of pumps that we use, a centrifugal system and a roller head system. First thing I want to look at is there really any difference between these two? And when I look at centrifugal versus roller head, there doesn't really seem to be. They seem to be about 25%. But it is interesting when you start looking in here, I do see some differences now between my centrifugal and roller head use of higher hemorrhagic complication rate, higher metabolic complication rates between these. And again, you have to, these are starting points to get you to start to ask those questions about where are these complications, why are they happening, and how can we use this. Now, I could sit here and go through these because I'm a geek and I like this kind of stuff, right? But the important point that you know is if you click on this and look over at the reports, you've got a whole bunch of different kind of reports you can do and you can look at that are there for your center. If you're entering ELSO data, this is here, it's available to you. And so I would encourage you to go and take a look at this and see how this data can actually inform and help you improve the quality at your center. The last part of this talk is where I want to focus, and that is talking about once you've seen an issue, how do you use this data to drive these quality improvement initiatives? We all should be doing quality improvement projects at our center to be able to improve our patient outcomes, improve the processes that influence the care, improve safety, and do all of those things. It's vital to what we're doing, providing a complicated technology such as this. Now, this is not going to be a talk on how to do that and all of the different tools and choices that you have in quality improvement. That is, there are degrees that are based on that. What I would say is you do have lots of tools that are available to you. The easy one I'm going to use and describe here is a plan, do, study, act cycle, a PDSA cycle, which many folks are used to hearing about and used to using in other settings. And I'll share with you a story about what we're doing at our center for this. And so the first thing comes in using that Explorer to be able to find problems. And so, for example, when we looked at our complications, we had cannula problems here, and we found a whole group of them which seemed to be worse than the ELSO average. So cannula problems at about 21% compared to ELSO at about 5%. Again, about double the rate of circuit changes and about triple the risk of thrombosis and clots in circuits. We were about the same for air emboli. But again, this makes you at least interesting to say, okay, these seem to be real outliers. And so when we drill down in that a bit more, again, when I look at it and look at the neonatal cardiac population, I seem to have about twofold the risk of cannula problems and about 2 to 2.5 times the risk of clotting problems. And so this gave us a place to go look to see, could we make change and could we figure out what underlie some of these issues? And so this is where a PDSA cycle comes in. And here's just kind of a common form that is used for doing PDSA cycles, talking about what you want to improve, generate solutions, choose one to test, and do a small pilot study, and then learn to act on it. And so we chose the issue of cannula problems. And so the first thing we went to go do was to make sure that our data definition was applied correctly, that the reason we were high wasn't just we were using the definition wrong, and so calling things problems that really weren't. Turns out we were doing that correctly. And so then we went and talked with a lot of the folks who were involved in this, talked to our bedside nurses, our specialists, talked to the critical care doctors, and then talked to the surgeons. And a common theme came up was that many people said that they knew there were cannula issues, but that the surgeons were reluctant to move these cannulas despite the evidence that there was an issue. Now, as part of this review, the nurses brought up to us that many of these patients also ended up with pressure injuries and had pressure injuries caused from that ECMO cannula itself. And excuse me, for those of you all who don't know, medical device related pressure injuries are a big deal, and they're actually the leading cause of pressure injuries in kids, which is who I take care of. They're also a very common complication of ECMO treatment due to the fact that many of these patients have prolonged sedation. They are in a fixed position to try and get flow to go well. And so this really sets them up for pressure injuries. And the smaller the kid, the more likely this is to be a problem. While I'd love to get my toddlers, up trying to crawl around my ICU on ECMO, it's just really not feasible. So those patients do end up with more sedation and lying there longer. And this is a common view of what it looks like. So this is one of our patients who had a cannula-related pressure injury. The cannula actually was inserted and went in down here. This is all from how it was sewn in and the force being placed on the neck there. And so what we went with was to do our PDSA cycle. We said, what do we want to improve? And the answer to that was these cannula problems leading to pressure injuries. We came up with the hypothesis that our patients, or that our staff, are forced to position these patients in cannulas in order to achieve the best possible flows. If our cannula problems were the cause of these pressure injuries, can we prove that this breakdown is occurring because of the reluctance of surgeons to reposition their cannulas? And so what are we going to do? If that's our plan, what are we going to do? Well, the first thing is we've got to evaluate the cannula sites and do that in a consistent fashion. And so one of the things that we came up with is a standardized form to be filled out and do and institute ECMO cannula site skin rounds, where we go, we look at each cannula, we talk about, and we do this each shift, talk about what kind of dressing was on, is there any problem, is there anything that needs to be done at the time. And we do that. Now, associated with that is the staff education that needs to go with this. And this is another important part of the doing process. And so we need to talk about what are the best dressings and repositioning aids. We have a set of wound care nurses. We need to, again, all make sure we're using the same definitions and are going and doing this the same way. And the other thing that we needed to do was to benchmark ourselves against other ECMO centers, in this case, pediatric ECMO centers, to say, what are you all doing and how are you approaching this same problem? Because as with anything in quality, many of these problems are, if not universal, at least very common, and learn from what's working from other centers. So The next part of doing is providing options. And so these are 4 different kind of dressing options that we chose to educate our nurses and staff about to help try and prevent this injury. And then the other thing that we had is this is something called a Z-Flow, which is a different pillow that helps redistribute the pressure on the patient's head to, again, be another resource and something they could use to try and reduce the chance of this happening. Now, I can't provide you a wonderful tie-up to this story because this is actually our current quality improvement process that we're doing. And so the skin rounds have begun. We've done our education of the staff. We're doing daily reviews of these data sheets, and this follow-up is going to continue over time. And so we'll do that PDSA cycle and then be able to report back on what we found and were we able to improve. Now, the other really important part of that quality reporting platform is you can build your tracking into it. So again, we haven't done this for this current project because we're just up and running. But if I go and show you our 2017 QI project, we actually did do that for it. And so we had a problem at our center with patients not being put on their prescribed rest settings, that we would come in and their ventilators would be much higher than we had proposed for them to be. Now, our data, the ELSO data here is in green, our data is in blue. I told you this was our 2017 project. If you were to go back and see our data from 2015 and 2016, only about 2/3 of our patients were actually on the prescribed rest settings that they were. So at our center, you're supposed to be on a peak pressure of 20. Is the maximum allowed PIP that we would set for any of our patients on rest settings. So we just made a binary, said you're either over 25 or you're under 25. We chose that as a marker. And so you see that by doing this, we were able to take our data from that roughly 2/3 level up to the point by just asking this question each day and doing a PDSA cycle on this, where we're now up to very, very high levels, where almost everybody is achieving this goal. So again, this is a way that you can do this, do one of these quality improvement projects, have it actually make a change at the bedside, but then also you be able to use this quality reporting platform as a way to hold everyone responsible for it, as well as to be able to generate these kind of charts and graphs that we need to be able to show administration why this is important and what it is we're doing at all of our sites. So the other plug I would put in for this is many of you all end up applying for our Center of Excellence Award. And these kind of projects are perfect for that award application. It is a great example to show how you're benchmarking against other centers, how you're using registry data, and the fact that you do have ongoing QI projects. Now, the one piece of advice I would give you is these are not short projects, and so don't just start them immediately. Take your time and work through them. So with that, I'll conclude. I hope I've been able to show you today that the ELSO Registry provides the gold standard for ECMO outcome data, and hopefully you've been able to see how this ECMO quality reporting platform provides a robust mechanism to implement your quality improvement projects. Thank you again for asking me to talk today. If I can ever be of any help to you, my email address is there. Thank you very much.
Terrific. Terrific, Dr. Paden. If we can bring him on. Hey, there he is, man. You're on mute, just so you know. There you go.
I got it.
How
Thanks,
are you,
Bill.
man?
I'm doing wonderful. And again, thank you for letting me give this talk today.
Well, it was a source of information. I can't tell you how many questions came across, so we can't possibly get to all of them. But a lot of the questions are asked from the audience, and you happen to answer those questions during your talk. So we have about 7 minutes that we can go ahead and take a few questions. And if you can join us later on at 15:10 Eastern, that would be terrific, and we can ask more. So I don't know if you can join us or not. I know you're very, very busy.
No, happy to do it. And I'll be there. See you guys later this afternoon.
Tremendous. Thank you, man. I guess one of the questions, and I'll let my other panelists go, is people are talking about, first of all, I wanted you to talk about why the registry is important, and you absolutely did that concisely. Why is it important? We have to go ahead and compare standards, compare the care with other centers. Now, one of the questions came from, I wrote the name down somewhere, but they asked about protocol sharing. We don't share protocols as an ELSO organization between institutions, but we have suggested guidelines. Can you mention something on that as far as ELSO?
Sure, absolutely. And so ELSO does promulgate a whole set of guidelines on a variety of topics, of clinical topics, everything from things from circuit design, and that's one of the areas where our perfusionists have really helped and have led that particular guideline that that we promulgate to help people with circuit design, all the way to anticoagulation protocols and just kind of regular clinical care things. And so all of that is available. And while ELSO itself doesn't there's certainly an art to all of this, which I think we all know. And while we don't share each individual center's individual protocols, know that most of the individual centers are more than happy to share anything you want. I'll speak for my center at Emory and Children's. I have a whole policy, set of policy and procedures that Michelle Hurd, who's one of our long-term coordinators, has put together. We share that freely with anyone who wants it. You know, perfusion and ECMO in general is one of those scenarios. Again, there is an art to it, and some of it is art and some of it is science. We're always happy to share with what we do, but I think what I'm always careful to say is this is what I am doing, this is why I am doing it. But for a lot of these things, we just don't have the randomized studies to say there's absolutely one right way to do it.
Right, and I note that I want to note that there's a directory with all the registered ECMO centers within the ELSO website, so you can get on that site and there's contact information for these centers if you have questions. Somebody had asked, how many ECMOs per year do you have to do to register for ELSO? So I'd like you to answer that, and I'd also kind of get an idea what percentage actually is ELSO capturing of all ECMOs out there. Let's say in the US at this
Yeah.
point. I know it's not as high as we'd like it to be because the more information, hey, the better data that we have, right?
No, absolutely. And so, if you have an ECMO program, or if you're even starting an ECMO program, so I got called just last week from a center down in Florida who's getting ready to start an adult and pediatric ECMO center. Reach out to us then. We again are able to help with some of that, help you get up and running, and do all of that stuff. We'd like you to be members there. All that we do ask in you being a member center is that you contribute your data into the ELSO registry. If you've got one patient a year, if you've got one patient every few years, it's still important that not only we get that data, but you get that data. Because for me, this is about providing the best level of care that we can for these incredibly ill patients, and benchmarking and knowing how you're doing compared to others ends up being vitally important. So we're here to help, and my email address is on there. If I can be of help, reach out to me. We're happy to do it. In terms of your question about what proportion of this we're capturing, it's a great question. It becomes a very difficult one. I can tell you we've got 227 centers within the U.S. And when you look, there was a study that was done a couple of years ago that looked at an administrative database, and this one wasn't done in kids. And when we looked at the number of centers who billed for ECMO at some point, and then looked at were they an ELSO center, the number was north of 90%. I don't remember exactly what it is, but it was essentially the vast majority of them. And we really need an adult study to be done the same way to be able to get a sense of that in the U.S. We know we're definitely, again, with 72% of the adult ECMO being done in the last 5 years alone, we know we're not capturing all of those centers, and we would certainly like to, because we think we bring value to those individual centers. But we really need a study like that to be done. Again, I think it's probably the majority in the U.S., but we really don't know. If you're talking about Europe, now we're talking in Europe, we're probably only collecting somewhere around the range of a third of all the ECMOs that are occurring in Europe. And it varies as we go around the world. In Southeast Asia, we're capturing probably 2/3 of the patients. So again, it just varies, and we want to be out there. We want to try and get this so that we can improve the care of all of these patients around the world.
Great, thank you. And for to find out about cost and registering, they can go to the ELSO.org website, or they can go ahead and call ELSO, which is based in Ann Arbor, Michigan, and they would talk to Peter about
Yeah,
that.
yeah,
Peter,
that's fine. Peter Rikus can help. Any of us are willing to help. If again, we put my email address on that on that talk. You can reach out to me, and I can get you all connected with the folks you need to be.
great, man. That is just incredible information. You lived up to the standard of Sanibel and exceeded it. We want to thank you, and we'll see you back at 15:10 Eastern time, and we'll move on to our next speaker. By the way, I loved your lung protective strategies in the neonates. We still need more and more of that as I travel around the country on mechanical ventilation while you're on ECMO. So thank you for mentioning that as well.
Absolutely, and hope to see you guys in Sanibel in person next year.
Absolutely. We'll have you back. Thanks,
Take
man.
care.